Hi, everybody. Again, I'd like to formally welcome you all to the Spasmodic Dysphonia Symposium. I wasn't expecting such a great turnout, and I'm really, really excited that you all came, and we're excited to talk with you. So, this is Dr. Jim Daniero. He's a laryngologist, which is a ENT that specializes in voice over at the voice clinic at the University of Virginia Health Systems. This is Joanna Lott. She is a voice specialist, speech language pathologist, works with Jim, and I am Dr. Nick Barone. I'm a professor here at UVA. I'm like in the health system side, and I specialize in research in voice and neurophysiology of voice production. What I want to, we're going to talk to you today about some of the things that we do and some of the kind of advances in some of the research, and really want this to be a discussion between us. We're going to talk for a while, but then we're going to open it up as a panel here in the front for questions. And please feel free to direct your questions at the whole panel or at an individual. And we're going to start here with Jim. Thank you for...
Sure, yeah, thank you. This is a great group. Thank you everyone for coming, I'm sure, from a good distance to get here. Hopefully the information we shared today is helpful to you personally or to someone, one of your loved ones. One thing, I gave a talk earlier this morning to the neurologists in the Movement Disorder Symposium that they were having just right across campus. I've kind of recalibrated the same talk because I think it speaks to the neurologists as well as to patients as well. Some of the voice problems that people in this room may have, but also some other family members or friends that may have some related voice disorders. And so Carol Doles, who's one of the coordinators for our regional support group, can probably give you more details on it, but the National Spasmodic Dysphonia Association has enlarged its target audience to be a little bit more than just spasmodic dysphonia recently, and it's grown to be voice disorders in general, and talking about vocal tremor, and I think would include some Parkinsonian voice, so a movement disorder that's related, but different than spasmodic dysphonia. So I'm going to talk a little bit about that to sort of kind of broaden the view of what the Spasmodic Dysphonia Association is now has under the umbrella, and to educate you all on some of those related voice disorders. And so one thing that I'll talk about is laryngeal dystonias, and particularly spasmodic dysphonia, characterize the different types and what the treatments offered, but talk about some Parkinsonian voice disorders, and how that relates to the differences in the qualities between spasmodic dysphonia and Parkinson voice disorders.
Jim, I'm going to interrupt you for just a second. I think people are having a hard time hearing. Okay.
Okay.
It's check.
Okay. I think there we go. I got a little more volume on it. And then I apologize. I just got from another talk, so I'm probably fading as far as my vocal endurance here. So we're going to talk about vocal tremor as well, and then we'll have everyone in the audience kind of pitch in to see if we can start making the diagnoses on our own. And so let's see if I can advance this.
Thanks for joining us. I'm Diane Rain.
This is a good test. I have this in here so I can test whether the audio is actually working. But this is Diane Rain. Everyone in the audience probably recognizes she has spasmodic dysphonia. She's very vocal about that. And let's see.
Thanks for joining us.
Is there any way to? It's on my side. All right.
Top news stories this week are the Democrats' victory in Congress and new leadership at the Pentagon.
All right. We'll try it again. There we go.
Thanks for joining us. I'm Diane Rain.
And so that's a voice that most people recognize from NPR. She had spasmodic dysphonia, and yeah. And so she had spasmodic dysphonia, has spasmodic dysphonia, and would receive Botox injections intermittently. She would have these breathy periods and then have a normal voice and then get worse with the breaks. And we could kind of follow that trajectory over time in listening to her broadcast, and would know sort of when she got her Botox injections. As people in this room that get Botox injections realize, there is that kind of waxing and waning course of effectiveness. But what is spasmodic dysphonia? And for those in the room that aren't familiar with the diagnosis itself, it is a specific type of dystonia, and that is related to a focal dystonia. So there can be generalized dystonia where people have movement disorders that affect their whole body, their ability to walk, their head turning, their eye twitching, their jaw twitching, their palate moving. This is the type of focal dystonia. So it's a bit unique in the fact that it affects the voice box primarily and some of the muscles that move the vocal cords back and forth. And but there's related type of focal dystonias that affect specific muscle groups, and that's blepharospasm or cervical torticollis, where the neck becomes cramped, or there's writer's cramp, where after writing the hand starts to cramp up. What we're talking about spasmodic dysphonia is the laryngeal dystonia, and that's the type of voice disorder that just affects, that's a dystonia or a neurologic diagnosis that just affects the vocal cords and the throat. And there's various different types. So typically, the more frequent subtypes are adductor spasmodic dysphonia and abductor spasmodic dysphonia. I'll talk about in a second. But it can also range down into chronic constriction type, where it's always tight and it doesn't have the classic breaks that we hear. That there's a breathing dystonia, so some patients will not have a voice problem as much as they will have spasmodic stridor. And so instead of activating with the voice, they'll have the spasms that activate with breathing, and therefore have an inspiratory kind of wheeze type of sound when they are breathing just at rest. And then there's a singer's dystonia, where the speaking voice is preserved, and it's the opposite of what typically we see, the speaking voice being preserved and having a dystonia or the spasm in the singing voice. Typically, we think of spasmodic dysphonia as the other way around. And that's one of the key diagnostic characteristics, that we may have emotional vocalization that's preserved. So shouting, singing, crying, and whisper. One of the things that we go through in clinic when we're analyzing patients, our speech pathologists and I will independently sort of evaluate how our patients are able to do these various tasks. And typically with spasmodic dysphonia, we'll have someone sing happy birthday, for instance. And some people that have come to our clinic have experienced that personally. And we have them test out their singing voice, some of which are more happy about it than others. I did have one patient, I don't see him here, but one patient that had a Weird Al Yankovic song memorized that sang. And so that was, he deferred the happy birthday and just brought his own song. But the most common type, 80%, is this adductor type. That's the strained spasms with speech. And specifically, it's the vowels followed by voiced consonants. And so we mow our lawn all year. And for when we have the voiced consonants, that's M's and L's and Y's, those followed by a vowel tend to cause a break or a spasm. And we can tell that we're actually using our vocal cords when we're producing certain letters, the sound of certain letters. We can actually kind of feel that on our throats. So if you go and mo, and we'll have some vibration coming from the vocal cords. But if you say Fat Freddy, only when we get to the vowel part does it actually get the vibration. So the F part is just airflow through the mouth, and it's just articulation with the tongue and the lips that produces that sound. When we have the former, the voiced consonant followed by the vowel, that causes the break. And that's very classic of the spasmodic dysphonia versus the abductor type, which is the opposite. It's the voiceless consonant followed by the vowel. We have a breathy break. And so we typically will find that our patients with the abductor will have an overall breathy voice, but it's not 100%. And that's because there's compensation. And sometimes the breathiness is covered up by the fact that we're straining against it. And it's really hard to tease this out sometimes, and we require some special trained ears in our speech pathologist to kind of tease that out, and sometimes even a little bit of trial of therapy to see if we can kind of unload some of that extra strain out of the voice so that we can really hear what's happening underneath that may indicate one type of diagnosis versus the other. And then 5% are mixed. So sometimes we hear both. And we say, okay, well, how are we going to treat this patient? What's the predominant type of spasmodic dysphonia that we're going to look to treat? And various treatment options exist for that. There's this great paper that our wonderful Dr. Barone was an author on. That was just you can see his name here. From Dr. Ludlow's group, where Nick had, Dr. Barone had done his training at JMU. But this consensus attributes kind of finally distilled all the things that we're talking about. So all those things that I just mentioned, the vowels and the consonants and how we put it together, this paper that Dr. Barone was an author on really looked at, what are those things that the doctors are looking at and making these diagnoses, and can we develop, a standard criteria for diagnosis between these different subtypes, and how to distinguish that from something like muscle tension dysphonia. And so these are kind of neat, and I'll just go through them a little bit with you. Some of it's a little bit too clinical, but just to give you a brief introduction. So spasmodic dysphonia, adductor type, so that's the closers, that's the voice consonants followed by the vowels. We said, number one, the higher up you are on the list for these criteria, then the better that criteria is for being specific and diagnostic. So that intermittent gap, vowel breaks on voiced sentences, so that's those M's, L's, Y's. The strangled and effortful tight voice quality, the increased in effort. And so folks that are in this room that have that know this really well. That's huge, and that's really one of the biggest complaints. It's just hard to speak, and that is one of the criteria. I mean, we're listening to patients saying, if you tell us that starts to make this diagnosis a little bit more likely. And for many that have been in the room and went to many doctors before they were diagnosed, realized that perhaps the doctors weren't listening enough, and went many years before they got their diagnosis. So these are the criteria that we're hoping are going to help improve diagnosis moving forward. Symptoms reduced with a whisper. This is, again, emotional vocalization, tends to be a little bit easier. Normal structure, so we typically will scope the patient and say, let's look at the vocal cords and see if there's any abnormalities there that we can really pick up on that might explain this, that wouldn't be dystonia. And then a little bit lower down on there is being able to see some spasms of the vocal cords. Typically, we don't really see that all that much. Mainly, it's a diagnosis that we make with our ears. The abductor type, so this is the breathy breaks before voiceless consonants. So that's that fat Freddy sells French fries. I tend to remember that sentence more than others for some reason. But the symptoms are most evident during the connected speech. So when we typically will have the little sentences for you to read, sometimes we won't pick it up, but then we'll just have a conversation. And through the course of learning about how a patient has come in and their story, we then say, now, I heard it right there. Yep, that was another word. Okay, I heard it there. That we might not pick up when you're reading this dedicated card. And again, normal anatomy. So ruling out other types of pathology that could cause some changes with the voice. But then distinguishing that from muscle tension dysphonia, which is often the sort of confounder in the whole process, is how do we pick out the patients that have effort, that has increased effort in their speech, they have a strained quality but they don't have those sound-specific breaks. It tends to be this tight voice that it's the absence of phonatory breaks in there that really kind of distinguishes that we're not having specific breaks that are reproducible over time. There may be some breaks, there may be strained quality, there may be increased effort, but the breaks are just missing there. And we tend to think maybe this could be a muscle tension dysphonia. And then on the laryngoscopy, this is where that part really comes in. This is the scope that goes down through the nose, or the one where they hold the tongue and look over the back of your tongue to see your vocal cords. When we see that, then we see some characteristic kind of squeezing or tightening of some of the muscles around the voice box. We can see that in some compensation, trying to self-manage the spasmodic dysphonia. But when we see that in the absence of the breaks, then we know this is more of this muscle tension dysphonia diagnosis that's likely to get better with speech therapy versus the dystonias, the spasmodic dysphonia, that often are not going to respond to speech therapy all that well. And finally, vocal tremor here. We definitely have breaks here, but they're regular. They're not very specific to certain sounds. So this is the kind of Katharine Hepburn voice of when we say E, instead of having E, and different breaks throughout that E. This is a E, 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 and we should, every time we have an E, it should be, as long as the E is there, we're hearing the same kind of rhythmic breaks. And that rhythmic break really helps us diagnose this vocal tremor versus the voice-specific breaks of spasmodic dysphonia. And the trick is here, so I make this all sound easy and that we should be able to make the diagnosis really easily, and how could a doctor miss this? But now we have some combination of, maybe you have mixed abductor-adductor spasmodic dysphonia with some overlapping vocal tremor. And then now it gets really complex, or maybe there's some muscle tension dysphonia components. So these are not exclusive of each other, and that's what really makes it a trialing a difficult diagnosis to make. So a voice specialist, and seeing a voice specialist, speech pathologist, and or laryngologist really helps to be able to distinguish some of the nuances. But there's that rhythmic quality and tremor. And then on laryngoscopy, again, this is where that scope really comes in handy. For those that have had spasmodic dysphonia, that have had many scopes done, and then most physicians will say, okay, well, everything looks normal down there, so I'm not sure what's going on. And that's good to see that it's normal in spasmodic dysphonia. But these other diagnoses, the muscle tension dysphonia and the vocal tremor, we'll see that there's actually changes there that we can pick up on the laryngoscopy that will show us it's vocal tremor. So there's two kinds of tremor, and I'll get into this later, but where we can see the vocal cords flapping in and out as a rhythmic contraction, sometimes with voice, but sometimes even at rest. And then we'll see the larynx sort of bob up and down, and that'll just be going on, and then you try and talk over that, and then you get that fluctuation, that rhythmic fluctuation in voice. And so back to the spasmodic dysphonia. So the incidence is 1 in 100,000. Average age of onset is 43 years old. However, it can happen at any point in the lifetime. We have patients that are under 18 that are diagnosed. We have patients all the way into their 70s and 80s that are first diagnosed. Twice as common in women than men. And then there's a 15%. I always get asked this question, is this the start of something else? Can it get worse? Can it spread? And typically over the first 18 months of a new diagnosis, there can be some variation, but after that it typically plateaus. And there's not much more attenuation in the voice quality. But there can be, 15% of people will have spread. So what we talked about was like a focal dystonia. So writer's cramp, or blepharospasm where the eye's twitching, or oromandibular dystonia where the jaw is kind of shaking up and down. Those are focal, but then we can have that progress to a regional dystonia in about 15% the time, which we would start with a laryngeal pathology or a laryngeal problem in the voice, and then all of a sudden we'll see blepharospasm come in several years down the road, or we'll see a shaking jaw that helps, that hurts the voice even more as far as voice production. But fortunately, that's fairly rare. The majority of patients will just have the isolated laryngeal symptoms. And then there can be relatives, so this does happen within a family with other types of dystonia. So it's not specifically spasmodic dysphonia, but in 8% of the time, this is in a limited subset, but there can be other types of dystonias. There can be vocal tremor that runs in a family, or Parkinson's disease that runs in a family. And that doesn't mean that if you have spasmodic dysphonia, you're likely to get Parkinson's disease. But there can be other type of neurologic disorders that tend to run in families that go along with the spasmodic dysphonia. And then here's the complicating factor is the overlap between vocal tremor and spasmodic dysphonia. And the 1/3 of spasmodic dysphonia patients will also have the tremor, and it makes the diagnosis just a little bit harder to tease out. So we're going to, after that primer, we're going to listen to a voice here and see if we can pick up what this is.
Rainbow
If it plays.
is white light, many colors. Please take shape all out arch, half of its two ends, terrific rising.
It's all the way up. So the E and the A are pretty good here.
For long, whole year, you'll get your egg. When you eat apples, oranges, it will always come away.
So those are the adductor sentences.
80, 81, 82, 83, 4, 85.
So this is series 80s. So all the 80s tend to exhibit adductor symptoms if they're there.
Fat and sells French fries. She saw the stars hit the hammer hard.
Those are the abductor sentences, so they tend to exacerbate the abductor symptoms. And the serial 60s.
4, 5, 6, 7, 8.
And so let's see, we'll do a show of hands and to figure out what people think. So raise your hand if you think that's adductor spasmodic dysphonia, the closer type. We got no takers on that. How about abductor spasmodic dysphonia, the opener one? Yeah, people are starting to raise their hands there. Any tremor there? Any vocal tremor associated with that? Anyone? And no. So he had a nice smooth E, and that's typical. So in abductor spasmodic dysphonia, and the folks in the room that might have that might notice that if they go for just an E, that might come out pretty smooth. And particularly, it's a classic abductor type of spasmodic dysphonia. But when they add that voiceless consonant right before, so he said, Harry hit the hammer hard. He was really trying to get his vocal cords to close for that vowel after that voiceless consonant, the H. And then struggled with that much more severely. Otherwise, you would have thought maybe his voice was pretty normal.
Hey, Jim, we
Yeah.
have to...
White
yeah.
light.
Okay.
This is good though. I mean, I think hearing that other, did you have another example to play?
I have many more, but I can.
Well, I'm really going to be very short because I had done sort of a little bit of what you just did because I thought I was going first. So I'm good. If you want to get, I'm okay.
I'm gonna talk about two different things, which is vocal treatment. So typically the treatment for spasmodic dysphonia is Botox as the first-line treatment. Voice therapy can be tried. It certainly can't hurt. But in the situation where voice therapy can help a little bit, But unfortunately, this is a neurologic disease, and it can help compensate, but it's not going to treat the underlying problem. And so what happens is we inject Botox into the muscle that is spasming, and it weakens that spasm. But it also does something else, because it's kind of interesting. We've learned that if we inject one vocal cord with Botox, we'll get the effect on both sides of the vocal cords. Both sides of the voice box respond. And we've learned that it's not necessarily the fact that we're weakening the spasm of the vocal cords, but we're changing the feedback loop. So because that vocal cord is a little bit different than it was before, your body perceives it in a different way. It's weaker than it should be. And then all of a sudden, the same way emotional vocalization is normalized in singing voice, the body has to do a little bit extra processing to figure out how I'm going to produce the voice. And because it's weakened, even on just one side, it does a little extra processing, and then the voice smooths out some. So some of it is the fact that the spasm can't contract as much, but it's also some neural processing of what's happening with the Botox that keeps it working. And so the other thing is, because our neurology colleagues deal with some larger muscle groups, and the overdosing Botox in that group tends to be less side effects, we're faced in the spasmodic dysphonia world with this, what I call a narrow therapeutic window, which means the dose we have to give you in order to give your symptoms improvement and the dose that we give you to give you side effects are really close together. And so the titration of the dose is really important, and it requires sometimes multiple doses and sometimes a year before we get to really what we think is going to be the optimal dose for patients. And we're talking about adjustments of a couple drops of Botox back and forth and saying an extra drop is going to give you the right result. And then we may have to decide, we're only going to inject one vocal cord at a time, and perhaps we're going to inject both cords with a lower dose, and there's a lot of titration that goes on. And then there's the surgical options, and I think I'll end here talking about the surgical options. And these they exist, they're out there. It's good to talk about them. I think really sort of weighing the pros and the cons of these surgical approaches and doing a lot of research beforehand is required. And so I'll talk a little bit about them. So thyroretinoid myectomy is essentially taking the muscle for adductor type spasmodic dysphonia, taking the muscle that we're injecting the Botox in, but basically just excising some of the muscle, producing some scar tissue in it that will then kind of stabilize the voice and be like a quote-unquote permanent type of Botox. The problem is it's cutting the muscle that helps you produce your voice, and it's producing scar tissue on purpose, which can leave you with a hoarse voice for other reasons because of the scar tissue that's produced in there. And I think the results are a little bit unreliable, whether or not that technique works. It works in certain people, but I think you have to do a lot of research because that's not reversible, that procedure. There's the laryngoplasty, and we typically use this in people who have abductor spasmodic dysphonia, and I've used it in a few patients that it's helped. It doesn't treat the underlying spasm, so the spasm still tries to push the vocal cords apart, and you get that breathiness. But if we make the vocal cords bigger, then the compensation's a little bit easier without having to strain so much with the voice to compensate for the breathiness. So while you'll still hear the same characteristic breaks of the breathy breaks, there'll be a little bit more room for compensation there. And then there's the classic procedure for spasmodic dysphonia, which is the SLAD-R procedure, the selective laryngeal denervation reinnervation procedure that was invented and popularized by Jerry Burke at UCLA, where the nerve that goes to the vocal cord is actually cut and then redirected, particularly to the adductor branch, is cut and redirected in some of the other neck muscles. And that has some downsides to it as well. If you do it on one side, there can be high recurrence rates, so then sometimes you have to do it on both sides. When we lose function of the vocal cord on both sides, there's a risk that the vocal cords don't open to breathe, And so that can be a really disastrous complication that can be fairly risky. And then there's also the chance that if it doesn't reinnervate just right, that it'll be permanently breathy, like a person who's got a completely paralyzed vocal cord. And again, that's permanent and not reversible. And so I would certainly seek out somebody who's done a lot of that surgery if you're considering going down that route. And then I'll end there. We'll take some questions, I guess, after all the talks. Is that right?
Okay. She's got one there, too. I'm just going to put the, not your slide, it was, I know, no.
Okay, sorry.
Sorry, we're trying to figure it out. We're good.
All right, let's see if I can get this working. Okay. Do I have to push it? Can you hear me? Okay. So I'm Joanna Lott. I'm a speech pathologist and voice specialist. I work with Dr. Daniero at the voice clinic here. I'm just going to talk with you briefly about my role, and this is maybe interesting, especially to the graduate students who are here, to understand, what can we do if the gold standard treatment for spasmodic dysphonia and tremor is Botox? What's the role of the speech pathologist? So I would say the answer to that is really heavy on the diagnostic side, in the perceptual voice evaluation side, because what we do as speech pathologists just naturally helps develop our ears. We have really good ears, whether it's for language or for speech, and especially for voice when you're working with voice patients every day. So my role is, what Dr. Daniero and I tend to do is not give each other the information we already have, because we want to go in unbiased in listening to the next patient. So if I suspect a patient has spasmodic dysphonia, or if they've been referred for spasmodic dysphonia, and we know that much, I'm not going to give them a yes or no if I see the patient first. I'm going to let him be the judge, and then we put our heads together and discuss. And I think that's a really helpful model, because especially for speech pathologists, we might tend to defer to the doctor, but there are definitely times where we'll just sort of look across the room at each other and go, oh, did you hear that? Because we hear it in the moment. But obviously, our tendency is going to be like, oh, well, if you think you hear this, then you hear that. But, it's almost like we would write it down on a piece of paper and hide it and then exchange. Not to make light of it or say that it's a game or anything, but it's part of our process, and I think it's an important part. The other part of what I do, I think, and what we do that's important is more of a counseling arm than a therapy arm. We do some therapy, and I'll talk about that, but the counseling part of what we do is very important. So my role is to meet with the patient in the evaluation if I suspect or if we've decided that we think they have spasmodic dysphonia, to help them understand that the treatment is to have realistic expectations, because the treatment isn't a cure and the Botox isn't an exact science, and therapy can only go so far. So we have to have a lot of discussions, and sometimes long discussions, answering the question, what does the Botox do? What are the side effects? And will therapy help? Those are typically the big questions. And the answers are not simple. So what Botox does is you get the injection, and then 24 or 48 hours later, you lose your voice probably, in most cases. And suddenly you have this breathy voice. And even if you've been counseled about this, it can still be surprising when it happens for the first time. And you might know and have it written down on a piece of paper from me that it's going to last up to 2 weeks, and in some cases longer, but it still can feel like, well, this is probably not quite, this is too much. I should probably get help. And so that's when the phone calls come in handy. So what we do in our clinic, and I think a lot of clinics have this model, is that we have the patient make a phone call, leave a voicemail during off hours, so that when I get in on Monday morning, I can listen to the patient's voice. They read the standard rainbow passage, so just this, paragraph, and then they hold out a sustained E so that we can hear, is there tremor, are there breaks, is their voice breathy, how weak is it? Then they answer a series of questions. Are you having swallowing problems? Are you having breathing problems if you've been injected for the abductor type? And have you noticed any tremor or spasm? Have you noticed that tremor or spasm has gone away? And how would you describe your voice quality? How does it sound to you? But not only how does it sound, how does it feel to you? And that's the one that patients almost never remember to answer. And it's funny because that's the one that they come in talking about at the evaluation. But I think it might just be because the answer is usually weak and breathy, which kind of describes both. So then the last question on the sheet is, do you need me to call you back? So my role is to call them if they have questions, and then in some cases defer, send the phone call on or the message on to Dr. Daniero or his nurse. And if the patient feels like they need to come back in, or things didn't quite work the way they wanted to, or they're having more side effects than they expected. And the other thing that's very confusing about the Botox treatment is the timing of when you'll get better is when the Botox begins to wear off. So that's confusing because I got the Botox injection so my voice would get better, but instead it's worse now, but you mean it's going to get better when it wears off. So it's a little bit counterintuitive. It's actually quite counterintuitive. But it's true. So I'll even sometimes sort of draw a timeline for them and go like, here's 3 weeks out, 4 weeks out. This is where we're going to be looking at optimal voice. And then somewhere around the 2 to 3 month mark, and in some cases longer, you're going to start to feel your voice deteriorate again. And so until we've done the injection a few times, we don't know exactly how long it's going to last, and we never know exactly. But injection after injection, we typically get a good sense. But there are some people, even in this room, who I know have decided to try, I don't want to have as long a breathy period, so I'm going to try just one vocal fold injection. One vocal fold side. And then have not the outcome they were hoping for, so come back in to get more. And then you just have the occasional times that, it's so unpredictable that people have a surprising outcome. So there's a certain amount of patience that's required for the patients that decide to go through this. The upside is that when the voice is good and it's functional and it can get you back to work. It can, especially if you have a job where you have to talk a lot. So that's pretty much my role, I think. I covered all the things. And we also have the patients keep a diary. So they keep a diary, especially for the first 6 weeks, and then some of them will keep it longer. And they're answering those same questions on a weekly or even daily basis, saying, my voice got, so that when they come in, we can see that their voice got better at 2 weeks, but it wasn't great yet. But by 3 weeks, they felt like they could do their job without any extra effort of talking. And then by 6 weeks, they felt like they didn't even have to think about their voice. And then by 8 weeks, they started to feel things get a little bit, return of symptoms happening a little bit. And then by, 3 or 4 months, things started to get bad again. So then I want to talk a little bit about therapy. And the reason I'm only going to talk a little bit about it is that I don't really do it that much for this particular diagnosis. Partly because I really strongly believe that Botox is, in most cases, going to be the best option. And I think if it were me, I would want to have the injections. But there are definitely times when if a patient doesn't have a good outcome, doesn't feel like they get what they need from the injection, that seeing a speech pathologist for voice therapy can be helpful. Again, there's some counseling that has to happen because the patient has to understand that there's nothing in voice therapy that can make the tremor or the spasms go away. But what we can work on is optimizing the voice you have by rebalancing how you're using your breath with how you're using your voice. And that's incredibly simplified. There's a lot of letting go of tension that has to happen. And there's no spasmodic dysphonia therapy. There's not a set way to do therapy for spasmodic dysphonia. There's one person, and I think there's only one, who has her own model of how you do therapy for spasmodic dysphonia. I don't know a whole lot about what she does. She has spasmodic dysphonia herself, so she developed this program based on her own symptoms. And she works with patients, and she gets great testimonials from them. They tend to seem to like her. But in watching some of the videos that she has online, it really looks to me like she's doing traditional voice therapy with these patients. But because of her probably level of empathy and insight into the problem, she might have a better sense of how to get a good result. I always find that if a patient comes in with a problem that I've had or am more familiar with, I have a tendency to feel like I can help them more quickly. But I will say, just as a caveat, I don't really know much about what she does. I think her name is Connie Pike. Do you know who I'm talking about? Okay. I just found her online yesterday and did a little bit of digging. But so there are, typically what we would do in voice therapy is get your air flowing, because if you think about it, when you're constantly having spasms in your voice, you're going to tighten up, right? Because your response is going to be, this is hard. And anytime something's especially hard, what do? If we have to lift something heavy, we tighten up, right? So even just if it's in your voice and it's hard, you tighten up. So letting go of that tension, retracting some of the muscles in your throat, opening up and getting that air to flow can be a first step. But you can't leave a patient there. You have to move on to helping them get the best sound that they can with the voice that they've got. And most spasmodic dysphonia patients I've worked with who didn't also have Botox, a lot of the conversation we had to have was about their expectations and keeping them realistic, because it's frustrating to come to therapy week after week and never leave with a normal voice. But the other thing that can be great is Botox and therapy. So when a patient's reached about the 5 or 6 week mark typically, they might benefit from coming in and working with me or one of my colleagues, or wherever you are, a speech pathologist specializing in voice, to do some of these techniques to help you gain, to just sort of optimize the results you're going to get from the Botox. And then hopefully maintain some of those skills that you learn in voice therapy and not have to do it with each injection, but just have to do it once. I've worked with only 1 or 2 patients who decide to do that, and it's usually helpful, at least per their report. And then I've worked with 1 abductor spasmodic dysphonia patient who, abductor, so the AB kind where the spasm is with the opening of the vocal cords, she found it to be helpful, but more helpful was drinking more water. So it's a little hard to say how helpful voice therapy is. But I actually love my role when it comes to the spasmodic dysphonia population and tremor population, because it's just a really interesting population, and a little bit, I admit, a little bit of a puzzle, a little bit of a problem-solving puzzle for me to work on with my colleagues, and I do enjoy that side of things. So that's my 15 minutes. Okay.
So I'm going to speak very, very quickly. And you're going to see me skip a lot of slides here, so just to be aware of that. So, as some of you may have seen, there was there was a article that just came out by Christy Ludlow, I think you said yesterday, that's what I was on my computer at the beginning, in which she's just reviews the what's happening with spasmodic dysphonia research. I grabbed a couple little points from that. We can see that the research in spasmodic dysphonia since 1950 has really exponentially increased, especially in the last 10 years. And it's really been a driver for a lot of voice research because of the number of papers coming out and people looking into it. One of the interesting things, though, about spasmodic dysphonia is that we know that Botox works. And so because we know that Botox works, it's hard to get funding to do a large multi-clinic study, randomized controlled study to really look at the effectiveness of it, which has sort of negative effects when it comes to insurance. Some insurance companies now say we need that or else we won't. We need the same level of research as if we were putting out a cancer medication. But in voice research, we don't have that type of funding. So many insurance companies cover it. I'm sure that you guys run into it where some are, question it and you have to send in multiple things. So we are getting more research out, though, especially in the last 10 years. There also been some research to look at the way that the brain activates and deactivates, or is overactive and underactive. And what this slide shows you is that some areas that are kind of cortical, so the areas that we have kind of our own volitional or voluntary control of are hyperactive, and the areas that are, and as well as underactive. And that kind of leads you to, like, is it underactivity in one area or overactivity in another area that is actually possibly causing or making this worse? But one of the areas that's important is this deep area. Well, I guess my pointer won't work on the screen. This deep area here, there we go. Here, called the thalamus and your, let me find, cerebellum, which is actually this area down here. If I can find my mouse again, there it is. Here, we can see these areas right there. So the thalamus and cerebellum are important for kind of combining a refined motor plan and organizing it. And without having looked into the research and just kind of understanding what I know about the way the brain works, there might be something to do, this might have something to do with the fact that without having that organization in a refined plan coming back, that might be something to do with the spasms. And the point of this is that deep brain stimulation is something that people are starting to look into, and actually putting a stimulator down in the thalamus and seeing if that would possibly improve vocal function in people with tremor and SD. And so really the point of this, and I encourage you all to read it, it was just sent out through the National Spasmodic Dysphonia Association email, is that there's hope for people with spasmodic dysphonia, and that there's more and more research coming out every year and new ideas about possible ways to treat it. And I'm sorry I just kind of had to do that real quick, but I wanted to make you aware. As far as this study, like I said, with the lots and lots of authors, really, again, I'm going to, Dr. Daniero actually went through most of these things for us, which was great. But we've had these tools that really aren't very helpful with people with spasmodic dysphonia. And some of you may have experienced where you go to the doctor, or you go even to a speech pathologist, and it takes years to get the diagnosis, because when we have things like muscular tension dysphonia and vocal tremor and even psychogenic disorders in which a person has something going on stressful-wise that's causing their voice to go out, it can mask what's happening with the spasmodic dysphonia, but it can also this looks like muscle tension dysphonia. It doesn't sound like to me. I don't have that much experience in spasmodic dysphonia, so I'm going to go with what I have a lot of experiences in, because that's what most people are coming into me with. So we wanted to create this measurement tool to identify spasmodic dysphonia, even though there are lots of other things happening. So we had 4 clinics nationwide. The first phase of this, we were looking at patients were just told, these are our patients with spasmodic dysphonia, MTD, and tremor, or some combination of those. And we took recordings of those, we had questionnaires, and we did nasoendoscopic evaluation, so putting the scope and watching it. I'm not going to talk about what those are, what we did in those, but we had then 4 external expert reviewers. One of those was Jerry Burke, who Dr. Daniero mentioned. The other was Christy Ludlow and a couple other people who rated these. But the problem was we had 11 categories that they could rate into. And when you have all these categories to rate into, you run into issues with reliability of the raters. And so we tried to cut these down to 7 categories. And the results, though, unfortunately, we had very low, for the 11 categories, we only had about 34% of agreement, which is low. That's not good. And the statistic for that is called CAPA, and anything below a 0.6 in your CAPA is bad, not good. So that 0.23 is very, very low. When we broke it down into 6 categories for our second phase, we ended up with about a 73% agreement between the raters, which is much better. I mean, that's a big improvement, but our CAPA value was still low. And so it wasn't significantly better. That's what that's trying to say to you, and that's how the research is working. All of these slides are just showing you, again, kind of what I just said and summed up. But we can see that we had, these are the self-identified classifications, and then classifications by the raters. And we can see that the raters classified similarly to what the sites classified as. But we can see there's an increase in tremor, a decrease in paralysis, and we're really kind of still all over the board, which is the whole reason we did this study. All of this is just explaining what I just said to you. We went to phase 2 of the study because of the low cap and low agreement, and we did this thing called a Delphi model, in which we kind of put all of the symptoms out there. We asked them, hey, the experts and the SLPs and the laryngologists that were participating in the study, which of these do you use? And then we took that and we said, okay, these are the ones that everyone are saying. Now it's to whittle it down to what are the important attributes of SD, MTD, tremor that you use to diagnose. And from those rankings, we were able to create this, which is the Spasmodic Dysphonia Attribute Inventory. And that was kind of the goal of the study, was to come up with a tool to rate a person, get a score, which we can see down here by the bottom, and say, okay, this person most likely has spasmodic dysphonia with MTD, or just spasmodic dysphonia, or just MTD, or just vocal tremor. And it's trying to help people who are help reduce that time, those from the symptom onset to actually finally figuring out this was SD or not. These are the 7 categories we, like I said, whittled it down to. And as I told you, we did have better rater agreement, but we did not have statistically better agreement. And that's what all of these little graphs are saying. The one main limitation of this study was that we were using the diagnosis from the center. And what did I just tell you about trying to diagnose spasmodic dysphonia? It's hard, and people get it wrong. And so one of the big limitations, the second one here, is that initial site classification may have originally been wrong. And therefore, it may have been that our tool was working better, but because we didn't match with what the initial site was, because of the issues with actually diagnosing this, we didn't come out with a statistically significant. And in research, we need to have that statistical significance. The other thing is that when we're using these videos and when we're using these audio recordings, as Joanna was saying, you're going to listen to them do their sentences, and we had to whittle it down. So they were doing sentences that could identify AD or adductor, and then sentences that could identify abductor. But we didn't just listen to the person speak. Speech pathologists, especially, from our point of view, and I know laryngologists like Jim as well, Dr. Daniero as well, we listen from the minute we walk in that door. How are you doing today? And we start listening. And we've honed our ear to listen from the very first moment until the time we say, well, listen, it's been nice seeing you, have a great day. And we gain a lot more information, not just from the actual test, but from all of that conversation around. And so because we were putting these into categories and only using these sentences, which we have to do in research to make it, so that we're not confounding the results. The actual study ended up having these, like I said, limitations to it. But really the conclusions was we improved some of the inter-rater reliability agreement. There was an increase between the raters, but it wasn't statistical. So, but we think this is a better tool to start using and to hopefully start to, like I said, separate out these categories more easily for people. Does anyone here have a combined diagnosis of SD and something else? Yeah, some people. Was anyone misdiagnosed at first, or took a long time to figure out that it was SD? Yeah, there's a couple hands that go up, and I'm not trying to single anybody out, but that was the point of this research. But as the first part of my little talk said, there is hope. We're trying to get better at it, and we're trying to do research to make sure that the clinicians and the doctors out there have better tools and resources to diagnose this. So thank you. And what we're going to do now is we're going to switch over to the panel, and we're going to open it up for questions.
There I am. What Dr. Barone just said, we also make mistakes. I mean, I hate to say it, but, well, actually, no, I take it back, we don't. So there are times when a patient will come in and it's presenting so much like muscle tension dysphonia that we'll decide that they should have therapy. And so, but we have a policy in place that if I do a session of voice therapy and I don't feel like they had any results, or their results are really not, what is the word I'm looking for?
Successful.
Okay, successful.
Therapy isn't very successful.
But that they have success and then they don't have success, they have success and then they don't have success. Intermittent, thank you, within one session. And I know even probably someone in this room has had this experience where then we bring in a second set of ears. So one of my colleagues or Dr. Daniero, if the referral came from an outside physician, to say, am I hearing what I think I'm hearing? Because it's really hard. That's how hard it is. And I think we're very good at it, but we still have times where I'll waste a patient's time because I'm just not sure. And, but we do our best.
And I don't think that's a waste of time. What I think that is part of the diagnosing process. So
it's sort of more, it's just a longer differential diagnosis process than we'd like it to be sometimes. Yes.
I have a daughter, that's why I'm here, who has spasmodic dysphonia. She's fairly young. I mean, she was diagnosed at around 17. Mm-hmm. So she's being treated with Botox successfully, to the extent that Botox treatments are successful. The limitations, but it's successful. But is there anything? Certainly, I didn't get a chance to look at that folder very well. But should she be considering at some point something more extreme? I mean, I was encouraged to hear this deep brain stimulation, and the various surgical techniques rather than facing kind of a lifetime of Botox and all of that, or are those risks just too great at this point?
So there are certain people that get great results with the surgery. It's just hard to predict who's going to have that great result, and I don't think we have been able to produce research enough to say who is going to have that good outcome. And the risks are they're not insignificant. The problem is they're permanent. And with Botox, it's not permanent. and you're not committed to a lifetime of treatment with Botox if you choose it. You can get the Botox until the time comes, and like we said, there is a lot of research going on that potentially there may be a better alternative for treatment. The problem is once you go down the road to a SLAD-R procedure or a thyroretinoid myectomy procedure, it's irreversible. So you may choose what is a substandard long-term treatment compared to what we have in 10 years. And for somebody who's 17 and has a lifetime to live with that voice afterwards, you know, it might be worthwhile to say, I'm just going to wait and to see how some of these things shake out with a little bit more evidence before we commit to that. And I think that's where we are right now with the Botox having very sort of predictable results and no long-term consequences. Unfortunately, it's a pain, it's a hassle. But when we do have that gold standard surgical therapy that works for everybody, that I think is going to be a better option, certainly for somebody who's younger like that. Because with a permanent procedure, that's going to be the result you have lifetime.
So you think there are hopeful prospects for the future?
There are, yeah. The brain stimulator is one, but there's several other really promising research studies out there. There is an implantable pacemaker that can go into the vocal cord and deliver electronic signals that works like stimulates similar type of reaction as Botox to the muscle that they're developing up in New York with Dr. Pittman's lab. So some of these things are real. It's just they're not prime time yet.
Can you speak about the surgery on those lines? There's a Spasmodic Dysphonia Facebook group, and a lot of the posts lately have been people going to Japan to have a surgery that hasn't been approved here in the U.S. yet. Can you tell us about that? What's involved?
I'm trying to remember exactly which one that is. The thyroplasty one?
T or something.
Oh, that's yeah. That's that, yeah. So that's the thyroplasty one I was talking about. I was talking about different use for that type of procedure for abductor spasmodic dysphonia, but for adductor spasmodic dysphonia, there is a different type of thyroplasty. So thyroplasty just basically means that we're changing the shape of the voice box so that the vocal cords are in a different position. And in a way, this is producing a more open configuration, putting more space between the vocal cords. So what I was talking about during the talk was putting implants into the vocal cords for abductor spasmodic dysphonia. So the vocal cords tend to spasm open. Putting implants into the vocal cords just push them closer together so that spasm isn't as drastic. So when the spasms open, they're still kind of close together, so it helps support the voice some. The spasms still happen. The Japanese procedure is the opposite. So that's taking the vocal cords and sort of putting a space between the two of them. So basically cutting the voice box and splaying the vocal cords open, and that's that titanium bridge. There's a little titanium bridge that goes in to just hold the vocal cords apart. And that, there's that, and granted, I don't know much about the results because I haven't seen a whole lot of that surgery and the results personally that have had that because it's not available in the United States, although I think there's a lot of interest among surgeons trying to learn that procedure. But that's on the horizon as well as a potential option, and I'm really interested to see what the adoption here in the United States is going to be. I'm sorry, yeah, you had your hand up.
Focused ultrasound ever been considered?
Yeah.
The deep brain stimulation is used a lot for essential tremor.
Right.
And they're using the
Focused ultrasound.
focused ultrasound for that.
That's an amazingly well-timed question, because I just came from the the Movement Disorder Symposium that I was mentioning the neurologists are having just across town, and Jeff Elias, who's one of the leaders in focused ultrasound, was there, and we were talking. The deep brain stimulator for vocal tremor, this is not for spasmodic dysphonia, but for vocal tremor, has some variable results. So sometimes people will get a better voice, but it's more rare that their voice improves. Their tremor, the hand tremor or the head tremor, if they have the other associated tremors, tends to improve. So the larger muscle groups tend to respond to the deep brain stimulator as well as the medical therapies. The vocal cords, for whatever reason, being these tiny little muscles, tend not to respond as much to deep brain stimulation. But I was talking with Dr. Elias about how focused ultrasound seems to work, and and we're actually going to do a research project on this based on the discussion I had this morning, that vocal tremor may have a little bit higher response rate than a deep brain stimulator as far as fixing the voice with focused ultrasound. So we're going to look at that, and I'm going to meet with him next week, and we're going to try and develop a protocol for it, so we can look at how the focused ultrasound, which is basically stimulating the thalamus, just like you're talking about, but using an ultrasound probe that's a high-powered ultrasound that we can target a specific area of the brain. So it sort of, in a way, overstimulates that part of the brain so that it weakens it. So in that part that's overstimulated that Dr. Barone was showing, the ultrasound will almost heat it up to the point where it doesn't function as well, because that overactive part, we're basically trying to calm it down with the ultrasound waves, and that's a permanent treatment. So that's a very well-timed question.
You say it's a permanent treatment?
The focused ultrasound? Yes. I mean, it's the equivalent of taking a stimulator into the brain and basically driving a signal, except it's the opposite. It's producing a lesion in the brain, essentially. So it's shutting down certain overactive parts of the brain using the ultrasound signal to just actually kind of burn up a little area, a specific area.
Is there a lot of chance to it?
It's pretty safe. So it's FDA approved for tremor in general, and there's no reason it can't be used for vocal tremor.
I probably have some residual from her, but I have a daughter who's very bothered by head tremor.
Yeah.
She's looking for some help.
Yeah, I think Dr. Elias would be a great person to start with. He has a clinic, a neurology clinic here. He's a neurosurgeon himself, but he works out of the neurology clinic because his practice is almost exclusively tremor and some Parkinsonian movement disorders.
Yeah. Right.
Could you address excess swallowing during the rapid phase? I mean, I'm just, if my Botox lasts to, say, 4 to 8 weeks, during that period of time, I am constantly swallowing, and trying to get rid of something in my throat. So I've noticed that your credentials address swallowing.
Yes.
Could you tell me
Yes.
what's going on?
So I'm going to back up a second and just say, is swallowing in general related to Botox? The typical side effects that we see is difficulty swallowing liquids and choking on the liquids, because the vocal cords, if you're doing it for adductor spasmodic dysphonia, your vocal cords are spasming closed. You're putting Botox in to help relax them, and they stay a little bit more open, which might allow some fast-moving substance like a liquid to sneak down between the vocal cords before they're shut, because they're weakened a little bit. So that's typically what we see with swallowing problems. Now, it's less often do we have the symptoms that you're describing, but you notice that they fluctuate with the Botox. So when you get the Botox, it becomes much worse, and then as it wears off, it gets better. And I wonder, there's one situation that we see some of this excess swallowing and throat clearing is with people who have thin vocal cords. And we see this in the Parkinson's patients, actually, with voice problems, where their vocal cords are very thin, and there's a breathy voice to start out with. One of the things that we see is the ability to clear the vocal cords of mucus is directly related to the volume of the vocal cords. And so when they're thin, we tend to accumulate mucus on them because our ability to throat clear do that. Our ability when we swallow to get the mucus off of the voice box is limited because the vocal cords just don't have that mass to be able to eject. So there's a weakened cough that's associated. I wonder if that could be an underlying issue that's exacerbated by Botox, because you're also taking thin vocal cords and then you're making them weak as well. And then that accumulation of mucus is because you're just not able to clear it or swallow it appropriately, and then it tends to sit around more. So that makes sense to me, but it'd be interesting to verify that with some studies. So either a swallow study or a laryngoscopy.
Now, as we get older, it is natural for your vocal folds as well as all your muscles pretty much to start to atrophy, get a little bit weaker and less mass, and that's the thinning of the vocal folds is a natural process that does happen with age. So, and I think we're going to take just 2 more questions, you two, but we're going to start with Rachel there.
Yeah, just a quick follow-up question to the focused ultrasound that you're talking about. I'm just curious if you're essentially shutting down the thalamus. Is that's the part of the brain?
That's correct. And now,
Not the whole thalamus.
not the whole thing. It's
Right,
actually
okay,
a good
Like
thing.
a very, very, this is like pinpoint. I mean,
Right.
the lesion you're talking about are
The thalamus itself is, about the size of a walnut, maybe, and we're talking about shutting down something that's the size of a grain of rice or something.
yeah. When you think of like a lesion, or think of like a lot of people when they think of lesion, they think of like a stroke in which you have this like what looks like, as I tell my students, looks like somebody took an ice cream scooper sometimes and scooped out a chunk of brain tissue. When we're talking about these lesions, we're talking, like you just said, we're talking about a tiny little spot that they've identified as being hyper or overactive, and we're saying let's shut that down, and hopefully that's going to help. So just one last question, and then we're going to move on to our second half. And remember, you can be getting up and eating throughout this whole time, please. Please feel free.
Okay, so really I have 2 small questions. One is shortness of breath. Is it related to SD? I have SD inactive, of course. And sometimes I have shortness of breath. And my pulmonologist is saying that it's because you have SD.
Yeah.
That's
So yes and no. I guess is the complex question. I'm going to let Joanna answer this, but just one quick caveat is that you should probably have, if there is a question about shortness of breath, you should probably have a formal pulmonary function test, which I'm sure they did.
all testing done.
And
Everything is negative.
in the sense that that's normal, then Joanna will comment on the shortness of breath.
I will.
Well, I mean, from the standpoint of breath support and the sense of,
Okay. Okay. Sorry.
I don't want to hog the stage.
I thought that I was in over my head for a second. I think, in fact, this is something that that was on one of my slides, and I forgot to talk about it. But like I was talking about with the type of therapy that we do with spasmodic dysphonia and tremor patients, is rebalancing the respiratory effort with the effort in the throat. And so sometimes the spasms or the tremor and the tension that comes along with that can give you a sense of breathlessness, or a sense of not being able to get the breath out. So there's sort of a feeling of being starved for air when in fact your lungs are fine and you're breathing just fine, and in fact maybe your lungs are full of air, but it's not going anywhere because it keeps the valve that should be opening a good amount of the time that you're speaking is wanting to stay closed. So balancing how tight your response to the tremor or the spasm with the breath is the target. And that's something that you might want to look into. You might be one of the people that could benefit from some therapy, in addition to if you get Botox injections, to try to help with diminishing that feeling through some different exercises. Sorry, I get it now.
Sorry.
It's okay.
Put you on the spot.
Last one, I was asking what speech therapist told me that Botox injection, you cannot take it for a well. So don't take it too many because you get knitted to it and it will not work. So is that true?
It's not true. Simple answer. You can have essentially with the low doses. So there's a difference. So there may be some idea that there's an immunity that builds up to Botox that comes out of the neurology literature and some of that world where they're injecting hundreds of units at a time. We're talking about injecting less than 5 typically for spasmodic dysphonia and tremor. And so with the hundreds of units that are injected for people that might have larger muscles in their neck and back that they're trying to weaken, you can develop an antibody to Botox, and that can create immunity over time, and especially if you're getting more rapid doses of the Botox. But for the doses for spasmodic dysphonia, we've not seen that happen at all.
So you can take it lifelong.
You can.
Yeah, the muscles you're injecting, I mean, they're minuscule, they're tiny. You're not injecting these big kind of, a lot of people think Botox, they think, getting rid of wrinkle lines. You're not injecting kind of bigger muscles. So I want to make one last point before we switch, and that's really directed to like the SLP students and stuff. You can't underestimate, and I hope that as we get into the next section where we're going to hear from some people who have spasmodic dysphonia, is you can't underestimate the importance of the counseling aspect of the clinical side, the speech side. People have different reactions to Botox. Botox can bleed into other muscles sometimes with, depending on, it never happens when Jim does it, but when other doctors do it. And that can, as Dr. Daniero said, that can be very scary for a person who has Botox. And those first 2 weeks, as Joanna said, can be very scary. And I'm sure we both, I'm thinking of a specific person who had a injection kind of go a little wrong and just didn't go back to the doctor for almost 9 months. And then it was so debilitating her, inability to communicate that she finally came back. But the whole session, she was in tears, just talking about what it was like. And so for the students, the counseling aspect is important, but also for the patients in the room. We understand where that fear is coming from, and we're trained specifically to address related to voice. We're not psychologists, but related to voice, to address those concerns and underlying fears. So please don't hesitate to look towards a speech pathologist for therapy and counseling related to your voice. So I really encourage you to do that. So we're going to switch over to the next part of this, and Carol is kind of going to take the lead here, and we're going to kind of become part of the people sitting and participating from that side. Yep, and this part's not going to be live streamed, so due to patient confidentiality. So, all right, and please feel free to get up. Let's take a 5-minute real quick break. We're going a little over, but if you have to leave, you can leave. But